Now it's my pleasure to introduce my very well friend, Dr. Noemi Reguart, and she will be focused on EGFR exon 20 insertions, not so uncommon disease with different treatment options. Noemi,
Last
welcome.
but not least, although I don't like to talk after Jordi because you are so great, so much information, so congrats for your talk. No, it's a pleasure to be here. Thank you, all of you, for organizing this terrific event, and I'm really happy to be here. I haven't been able to be here for the last couple of years, so I'm glad to be here and enjoy with all my friends this meeting. So I'm going to talk about the last EGFR mutations that I think we haven't talked about, which is exon 20 insertions. And the title, it says, no so uncommon disease, but I have to disagree a bit because I think they are quite uncommon, although it might be possible that we are underestimating its prevalence, and we will talk more about this afterwards. So this is a mutation that it is found in about approximately 1 to 2% of our non-small cell lung cancer patients, although this is falling apart, so sorry, the micro. Although, as Jordi said before, it's the most common type of genetic alteration among the non-classical mutations. One thing that is very important about this genetic alteration is the diversity. There have been more than 100 described. And another important thing is they can be located at the different sites of the gene. You can see it here. They can be located in the C helix, or they can be located in the loop following the C helix. And this is very important because you will hear a lot about talking about where is the insertion located. It's located in the near loop, or it is located in the far loop. And this we are trying to figure out how this is important, but it seems that it's going to have an impact in the activity of the different therapies. But as you can see here, most of the insertions are clustering here in the near loop, which is just following the C helix. Apart from that, I could say these genetic alterations are very similar to the other ones, are more common, are mutually exclusive with other genetic alterations, and they are enriched in females, in Asian patients, and in non-smokers. But there's one thing that differentiates them, and Jordi has talked about this, and I'm going to reinforce it, and it's that they have a specific structure that differentiates them with the common EGFR genetic alterations. And this is because exon 20 insertions block the drug binding pocket by reducing the size of this binding pocket, rendering the tyrosine kinase inhibitors inaccessible to this site. And this is why most, not all, but most of the insertions, patients with mutation or insertions in exon 20 are resistant to early generation tyrosine kinase inhibitors. Though the things get complicated because not all the patterns of sensitivity to tyrosine kinase inhibitors are the same. You can see here, depending on the location of the insertion, helical, near loop, or far loop, you can see there that there's a lot of the heterogeneity. So it doesn't clear if it's because of the different structure, or if there are other things that are explaining this data, but as Jordi commented, it could be that only the different conformation of these different insertions located at different sites could provide this difference in sensitivity. So this might be very important in the future when we select for treatments. And for example, genetic alterations located, insertions located at exon 20 are considered as classical-like because they are very sensitive to early generation tyrosine kinase inhibitors, whereas the other ones, as you can see here, the classical insertions at the loop are considered to be mostly resistant to early generation tyrosine kinase inhibitors. At the beginning, I said, this is a genetic alteration that we consider it's infrequent. We don't see it a lot in our clinics. And probably we might have been underestimating the incidence of this genetic alteration. And this is very important because unlike EGFR genetic alterations, when we are using hotspot techniques such as the commonly used COBAS or TheraScreen, maybe we are missing all the patterns of insertion that we can find in all the exon 20. And indeed, it has been shown that when we are using these COBAS and TheraScreen, we can miss up to 15% of the insertions. So that's why maybe in the near future, with a broader use of the NGA, we are going to see more and more and more exon 20 insertions in the clinic. And that's why also the guidelines clearly or strongly endorse the use of NGS instead of these hotspot techniques to identify these patients with exon 20 insertions. And these differences, specific patterns, structures, and probably also because we have been underestimating the genetic alteration and the classical resistance to early generation CKRIs explains this figure here. And indeed, it took more than 20 years since the first approval for the common EGFR alteration to have a targeted drug approved. It was 2 years ago for patients with insertion, exon 20 insertions. And that also explained this lack of developments for the last 20 years, why these patients have been always considered as patients with really poor prognosis. And you can see here common treatments such as chemotherapy or immunotherapy fall far short from those of patients with common EGFR mutations treated with tyrosine kinase inhibitors. And an important thing also, you can see it in here, the predictive value when using early generation tyrosine kinase inhibitors is very low. And you can see here overall response rate with afatinib, with erlotinib, with first generation, early generation inhibitors, even osimertinib, overall response rates of only or less than 10%, and median progression-free survivals of only 3 months, which is completely different with what we see in patients with common EGFR mutations. So we were in a high need of effective therapies in this specific subgroup of patients. And we have had 3 strategies that have been explored. The first one is using bispecific monoclonal antibodies. We are going to talk about this, amivantamab. And then the other strategy is to explore other different, novel, more compact, more selective for exon 20 insertion, tyrosine kinase inhibitors, and even combinational approach by blocking the outside and the inside of the EGFR signaling. But for sure, the first drug that has impacted outcomes in patients with exon 20 insertions has been amivantamab. And the first evidence of the activity of amivantamab, which I remind you is a bispecific MET EGFR antibody, was seen in the Chrysalis trial, which explored amivantamab monotherapy in patients that have been previously treated with chemotherapy. And we saw robust and prolonged responses, median progression-free survival of about 7 months, with overall response rate of 40%, and median overall survival of 2 years, with this 2-year landmark rate of almost 50%, which compares, which is clearly higher than the 20% that we were seeing when we were using the classical chemotherapy or immunotherapy that we use in clinical practice. So with these results, they were enough. It was a high unmet need to approve amivantamab as monotherapy in the second-line setting for patients by the FDA and the EMA for the patients with exon 20 insertions. And this led the hope that maybe using amivantamab combined with something and moving it to the first-line setting could improve response, could improve outcomes, could improve for progression outcomes for patients with exon 20 insertions. And that was explored in the Papillon trial. I'm sure you are all aware about this trial, but I only want to remind you a few things. The first thing, the stratification factors, ECOG-PS, brain metastasis, and also prior TKI use. Importantly, very importantly, because this is something we can discuss afterwards, patients with brain metastases were allowed to be included in the trial. However, like other trials, in here, patients had to be previously treated with radiotherapy and had to be stable without symptoms. And another important thing is that after progression, those patients that were in the control arm were allowed to cross over to amivantamab. And this is very important also to keep it in mind when we are reading the results. And you can see here that more than two-thirds of the patients received amivantamab at second line after progression to chemotherapy. And this was a really clear positive trial. You can see the curves that separate PFS curve, which was the primary endpoint, how they separate early in time. Amivantamab combined with chemotherapy in the first-line setting, improved progression-free survival, even it almost double progression-free survival from 6 to 11 months with this hallmark 18-month, 10-fold improvement from 3% to 31%. And also, it was seeing higher activity from around 50% to 70% overall response rate used when we were using the combination. But there's I could say not the dark side, but the side we don't like that much from amivantamab, but is there, which is a safety profile. And we are getting more used to this because we are using more and more amivantamab, as I would say, that we are more comfortable with this type of toxicity. And this toxicity is mostly related to the EGFR and MET inhibition. And if we look at the grade 3 or higher adverse events induced specifically by amivantamab, we are going to see them in approximately 40% of the patients. However, it's reinforcing this to see that when we are combining chemotherapy, at least regarding this toxicity, cutaneous toxicity, the safety profile is very consistent with that, the single agents alone. So if we want to balance this efficacy and the safety, we have to be proactive, we have to educate our patients, and now we have resources. And we have several trials, the Paloma 3, the SKIR, and the Cocoon trial that have demonstrated that if we give prophylactic treatment to the patients, we can ameliorate these symptoms, which is going to improve for sure quality of life for our patients. So that's what we have right now. We can give amivantamab plus chemotherapy in the first-line setting, the Papillon, but also we can have the possibility, and it's approved, to give amivantamab after chemotherapy in the second line. Both guidelines have these two options in their algorithm. However, both guidelines, ESMO and NCCN guidelines, clearly endorse the use of the combination in the first-line setting. So maybe we would like to see other endpoints, or which endpoints we would like to see beyond PFS to help in guiding decision when we have to select treatment strategies. And there are other insights, secondary insights from the Papillon. The first one is treatment with chemotherapy and amivantamab also improve the time to symptomatic progression and also the patient-reported outcomes. And importantly, it impacted on outcomes on the first subsequent therapy by decreasing in 51% the risk of second subsequent progression despite the 66% crossover rate. This is good. This means that beyond the first line, amivantamab, it's also impacting in the post-progression therapies. However, we would like to see other endpoints. Overall survival is still immature. It seems that they are there, the curves are opening, but we need more maturity of the data to have this clear idea that the first line treatment is impacting outcomes, and we don't have one very important thing that is data on the brain activity of this combination. And another important thing is what do we do after these patients progress to amivantamab and chemotherapy, and we have to remind that at the end we have a patient in front of us and we want treatment strategies. So we need to do better, and we need to have other treatments after amivantamab and chemotherapy, and to give more strategic options to other patients. And indeed, if you look at the subsequent therapies of the Papillon trial, after chemotherapy and amivantamab, 50% of the patients received, again, chemotherapy. So we need more therapies. What do we want? If I say, raise your hand, oral treatments, I want them. Okay, chemo-free regimens, all want them. And we want drugs that go to the brain and protect the brain. And that's when the tyrosine kinase inhibitors come. And there are a lot under development, though we don't have any of them right now approved, but there are a lot that are being explored, and a lot of them indeed had reached already a late phase of clinical development. And the first one that was reached approval for this subset population, although for a very, very short time, was mobocertinib. Mobocertinib was a very nice tyrosine kinase inhibitor that was quite highly selective for exon 20 insertion. And as you can see here, in the first study, phase 1/2 study, the EXCLIMB study in patients with exon 20 insertions previously treated with chemotherapy, you can see here that the activity that was seen was very similar to that seen in the Chrysalis trial, with overall response rate 37-month PFS, median overall survival 2 years. That was outstanding. That was active. However, one important thing or concerns were the diarrhea, around 20% of grade 3 diarrhea, which was quite high. And also, the EXCLAIM-2, that thank Jordi was just published yesterday, the day before, the EXCLAIM-2 trial, which is the phase 3 trial in the first-line setting comparing mobocertinib versus platinum double in this double treatment in this specific subset of patients, was a negative trial. You can see there the PFS was exactly the same, and the trial did not meet its primary endpoint as it did not cross the specific futility boundary. So unfortunately, this drug at the end was finally withdrawn from the market. That was a company decision, although the drug was active as monotherapy in second-line setting. And then we have other tyrosine kinase inhibitors. And I have put those two in the same slide because they have quite similar safety and activity. This is zumbocertinib and fulmocertinib. Those are EGFR HER2 inhibitors. You can see very nice how these more specific and selective exon 20 insertion inhibitors, how they have really nice activity in treatment-naive patients, around 80% overall response rate, but also in previously treated patients, around 50%. Safety profile, I could say, well, it's, I would say, in the middle. There's really low manageable toxicity in terms of almost no grade 3 toxicities. However, there's quite a high incidence of diarrhea and rash because this treatment, these tyrosine kinase inhibitors, because of the off-target wild-type inhibition of these tyrosine kinase inhibitors. We have 2 registrational trials ongoing, both of them in first line. Now, none of these drugs are studying phase 3 trials in the second-line setting, which is a setting in which we could really need also this type of therapies. And those both are studying these tyrosine kinase inhibitors as monotherapy versus the standard treatment with chemotherapy. Then we have zipalertinib. Zipalertinib is I would say, completely different tyrosine kinase inhibitors because in the sense of the high selectivity to mutant wild-type EGFR, and this is translated to a better toxicity profile. If you can see here, no diarrheas observed and really lower rates of cutaneous toxicity. So this could be a future advantage of this drug. And you can see here also very nice activity in range of what's seen with the other two tyrosine kinase inhibitors, 40% in previously treated patients. But in here, the phase 3 trial in the first setting is not studying the tyrosine kinase inhibitor as monotherapy, but combined with chemotherapy. So we have two agents studied in first line as monotherapy. This one we combine with chemotherapy. And unfortunately, although, for example, tipalertinib has been designed to cross the brain barrier, we don't have data on the activity of these agents. We just have some anecdotal responses. So we need agents more active that go to the brain, that have brain activity, and we have some of them, at least ORIC-114, because the blue development, the blue 451 has been shut down from development. And so we have this one here, ORIC-111, for which we have seen it have been reported very nice complete responses in the brain. It has preclinically evidence of high intracranial activity, so it'll be very nice to see how this further clinical trials in phase 2 give further information on the activity of these drugs in the brain. Then we have some trials that have studied the dual or combinational strategy, blocking the extracellular and the intracellular. This is was mentioned before. This is the Becotaroac, which is an EGFR molecular antibody combined with osimertinib. Also very nice activity, overall response rate 50%, but look at here, grade 3 or higher at adverse event, 80% of the patients, so that it's going to be very difficult to handle in really clinical practice. So I am almost finishing now, so this is, was thinking what's the future hold for sequential therapies for EGFR exon 20 insertions, and I wish I had the crystal ball because I have no idea, because things change a lot. So I always like to do that kind of algorithms that Jordi likes to do, and I don't know, I did this one, maybe I'm wrong, but let's see what the future tells us. So right now we have these two options. We have amivantamab chemotherapy. We don't have any specific therapy after progression, and we can give chemotherapy, amivantamab, and monotherapy. But we have these phase 3 trials ongoing. We can have, in future, we can have a tyrosine kinase inhibitor monotherapy, or we can have the option of tipalertinib combined with chemotherapy at front. So those two trials, we will have to see how the final result on how the monotherapy or the combination of chemotherapy with a TKI prevails in this first-line setting, but then after that, we will have to decide whether to follow with amivantamab chemotherapy or amivantamab monotherapy, and we will not have enough evidence for this sequence. And another thing that might happen is that the activity, seeing the preliminary activity of these agents in early phase 1-2 trials, it might be possible that these results these studies have similar activities. So at the end, we will have to decide based on other factors. So we'll have to decide based on our oral preference. We will have to decide based on the chemo-free preferences, and then maybe we'll have to decide based on other factors for which we still don't have information, such as baseline factors, commutations, what's the role of the efficacy depending on the insertion location, or what is the activity, or what is the activity of these different combinations in the brain, or how these different sequences are going to influence in their resistance. So this is what we have right now. We have very little hints of information about all these factors. the location of the insertions, the activity in the brain. We also don't know what's the role of commutations and have no information on the pattern or resistance. So we'll have to wait next year, the readout of these new trials to see if we can get more knowledge to better decide how to sequence these treatment strategies. So amivantamab plus chemotherapy or without chemotherapy, it's a new standard of care for patients with exon 20 insertions. There's an evolving landscape there. We have new tyrosine kinase inhibitors with results that are promising and that might, in the phase 3 trials in the first-line setting, might provide similar outcomes to what's observed with AMI chemotherapy, but we have to wait to the final results, and there will be a lot of questions to answer. We have to address how, we have to understand and to know how to address all these different therapeutic options. We need more information and dedicated trials in those patients who have brain metastases. We need to have also more information to see if in reality the differences in activity by region location that is seen in preclinical studies are reproduced in these clinical trials, or whether the tyrosine kinase inhibitors or amivantamab chemotherapy might have different activity according to these different regions, and also how these different sequences are impacting on resistance. So thank you so much for your attention.